Bismillah. Welcome. We'll talk about non-insulin glucose lowering therapy in type 2 diabetes today. So those are the outlines of the talk. We'll talk about assessment of patients who are just newly diagnosed type 2 diabetes. And then we'll talk about when to start diabetes medications. And then we will talk about the glucose lowering medications. So we'll focus initially on metformin, and then we'll talk about the other options. Which one do you use and when should you use them? So let's start by this case. This is a 41-year-old man with no past medical history. He had a routine checkup. He had a fasting glucose of 180 milligram. His A1C was 8.3. His kidney and liver function tests are normal. And the question is, how should we approach this patient? So let's look at patient assessment. So this patient fasting glucose is 180, 10 millimole. And his A1C is 8.3, so he has two criteria, right? So his fasting is more than or equal 126, and his A1C is more than or equal 6.5, so he has diabetes. So let's start with the history of patients who are just newly diagnosed with diabetes. So you want to ask about their lifestyle patterns. How is their weight? Had they tried to lose weight before? Are they overweight? Are they obese? What kind of physical activity are they doing? How frequent and how much? Smoking and alcohol are important to ask about. Comorbidities, do they have anything else such as hypertension or high lipids? Are they taking any medications? And then family history, especially of diabetes and cardiovascular disease. On physical exam, it's important to look at the blood pressure, weight and height to calculate the body mass index. Thyroid exam, foot exam is important. And then you want to do a focused systematic examination. What laboratory tests we need for newly diagnosed diabetes? An A1C is important, lipids, a creatinine and a GFR. Serum potassium is needed if your patient is on ACE, ARB, or a diuretic, so something that can affect potassium. ALT and AST. Urine albumin to creatinine ratio is important. And then TSH only done for type 1 diabetes. So the question is, what should be glucose targets in diabetes? And the answer depends. So there are several factors that we look for to decide on the glucose targets. Age is very important. Comorbidities, especially vascular disease or other conditions. How long had they had diabetes for? Life expectancy. The risk of treatment. So the A1C target in diabetes, in general, the A1C target in most patients is less than 7. For some patients, you may aim for less than 6.5, and this is if you have maybe young patients who have long life expectancy and they don't have cardiovascular disease. And this approach has been shown to lower the risk of chronic kidney disease and retinopathy. In some patients, you may want to relax the targets. Those are patients who have advanced complications, or they have extensive comorbid conditions, they are functionally dependent, or they have a history of severe hypoglycemia, or have a limited life expectancy. In those persons, the aim is around 7 to 8.5. The home glucose targets, according to the American Diabetes Association, before meals around 80 to 130 milligram. Again, those are general targets, depend on the patient. And in some patients, you may want to check 2 hours after meal, and the target is less than 180 milligram. So the initial approach for type 2 diabetes for all patients should include lifestyle changes. And this includes medical nutrition therapy, what's called diet, physical activity, and education. Behavior change is very important. So for education, this is usually assessed by a certified educator. The dietary plan is usually assessed and planned by the dietitian. For physical activity, the aim is to have a target of at least 150 minutes a week of moderate to vigorous intensity aerobic activity. And this should be done over 3 to 5 days over a week. And the goal is not to stay more than 2 consecutive days without activity. So the question is, when should we start medications in type 2 diabetes? The American Diabetes Association and Diabetes Canada suggest to start metformin at the time of diagnosis. The Canadians actually also suggest that you can chance by lifestyle changes only. If the A1C is more than 1.5 over the target, you may want to consider to start by 2 medications. So the first choice is, as you know, metformin. And let's talk about the benefits of metformin. Why is metformin the first choice? It has a high efficacy, A1C lowering around 1 to 1.5%. It very rarely causes hypoglycemia. It may be associated with weight loss or at least weight neutral. It has a low cost. There's a lot of generic now. And it's shown to have potential reduction in cardiovascular events and mortality. So how do we start metformin? So the starting dose is generally 500 milligram twice a day for a week or 2 weeks, and then we want to go to the maximum in all patients. We want to achieve the most benefit from metformin. So we want to give all patients 2 grams a day. And you would take it with meals. Some physicians give it after meals. If you have a GI upset, and this is important, I tell my patients I will start you on 500 for 2 weeks, let's say, and then after that you go to 1 gram twice a day. And I advise them, if you have symptoms on the 1 gram twice a day, don't stop metformin. Go back to 500 twice a day. Some patients will do fine on the low dose. Some patients are even intolerant to the 500 twice a day. And here you have the option of trying the extended release form, which is once a day, which is shown to be more tolerable, or in some countries there's oral solution of metformin. Important to mention that the maximum effective dose is 1 gram twice a day, even though that some references mention that the maximum dose is more than that, maybe something like 2.5 grams, but the efficacy is not more, so you don't gain any much by going more than 2 grams a day. Some physicians give metformin 3 times a day. I find that hard for the patients to adhere to a medication 3 times a day, so I tend to not use metformin 3 times a day. So how about the kidneys? How about the problem with the kidneys? So you need to obtain a GFR before starting metformin. If the GFR is less than 45, metformin should not be started. If the patient is taking metformin and the GFR goes low, the GFR between 30 to 44, here you need to assess the benefit and risk and you need to decide. And some guidelines suggest to reduce the dose if the GFR in this range. If the GFR is less than 30, metformin has to be stopped. What are the side effects of metformin? GI side effects, nausea, vomiting, and sometimes diarrhea can happen. Vitamin B12 deficiency can happen in some patients. There's a recommendation by the ADA to do a periodic monitoring. No clear guidelines on how frequent. Some people will do it once a year, and especially if there is anemia or peripheral neuropathy. If you have a patient who has unstable heart failure or he's hospitalized for heart failure, it's better to stop metformin. Metformin can be continued if you have a stable heart failure. If you have a patient going for a contrast procedure and the GFR is between 30 and 60, it's better to stop metformin at least 24 hours before the contrast procedure and then check the creatinine after 48 hours to make sure that it did not get affected by the contrast. And very rare can have lactic acidosis. Case number 2, this is a 42-year-old man with type 2 diabetes for 2 years. He's on metformin 1 gram twice a day. He had already education on diet and exercise. His exam only showed a body mass index of 28.5. His A1C is 8.2. His kidney and liver function are normal. And the question is, how should we approach this patient? So let's look at the patient assessment. So his A1C is clearly uncontrolled, 8.2, and the target A1C in this patient should be at least less than 7, and some even may be aggressive and aim for less than 6.5 since he's young and he doesn't have cardiovascular disease. So he's already following lifestyle changes. We need to assess adherence, of course, to metformin, but here clearly metformin alone is not enough. So we need to add another agent. And the question is which medication we should use. So let's look at the options we have after metformin. Sulfonylureas, DPP-4 inhibitors, glitazones or TZD, GLP-1 receptor agonist, SGL2 inhibitors, and basal insulin. Meglitinides and alpha-glucosidase inhibitors are now rarely used, so we will not go over them. So let's start by what is best after metformin, which agent is best. And so far, we don't have a clear advantage of any medication, in general, of course. But we know that the decision is based on certain factors. So if you have comorbidities such as atherosclerotic cardiovascular disease or heart failure or chronic kidney disease, this may favor the use of certain agents. The risk of hypoglycemia is important. The effect on weight, as we know that some agents may increase weight and some may actually reduce weight. The side effects is important. Cost is extremely important. And then the patient preference, as we will talk about later. So let's start by sulfonylurea. Sulfonylurea, as you know, they stimulate insulin release. They have been available for a very long time, more than 50 years. We have a gliclazide MR, and the starting dose is 60 milligram. The maximum is 120. We have glimepiride. The starting dose is 1 or 2 milligram. The maximum dose, even though that some references use 8 milligram, a lot of people like us will go to only 4 milligram. There's not much difference between 4 and 8 milligram. Glibenclamide or glyburide in some countries and glipizide also can be used, and the starting dose is 2.5 or 5 milligram once a day and can be increased to a maximum of 10 milligram twice a day. So which sulfonylurea is best? And the answer is all have the same efficacy. However, glibenclamide has been associated with more hypoglycemia than the others, but it has the advantage of very low cost. So in some countries, that's what's used after metformin. It's important to mention that most of the benefit is seen with half the maximum dose. So if you are on sulfonylurea at half the maximum dose, don't count much on a lot of benefit if you go from half to full maximum. And the UK PDS study showed no increased cardiovascular events with sulfonylurea. So the advantages and disadvantages of sulfonylurea, they are effective, especially in the first few years of the disease, A1C lowering of 1 to 1.5%, and they have a low cost. The disadvantages, as you know, hypoglycemia, weight gain, and they tend to lose efficacy by time. So they have a high rate by time of secondary failure. Let's talk about the DPP-4 inhibitor, and this will bring us to the incretin system, which is based on a molecule called GLP-1 or glucagon-like peptide 1. And this interesting molecule has 4 actions. It stimulates insulin secretion, it decreases glucagon secretion, it decreases appetite, and it decreases gastric emptying. So all of those actions are favorable in diabetes. So this GLP-1 is broken down by an enzyme called dipeptidase 4 or DPP-4. So if we can inhibit this enzyme, that will remove the block on GLP-1, and then you have more available GLP-1. And here comes the idea of DPP-4 inhibitors, or what's called glutens. So they can be taken with or without food any time of the day. We have sitagliptin, vildagliptin, linagliptin, saxagliptin, and others, and here are the doses. And there are combinations available with metformin. The advantages is they're generally well tolerated, so the side effects with them are not common, and they are not associated with weight gain, and rarely to cause hypoglycemia. The disadvantage is they're not very powerful, so A1C lowering around 0.6 to maybe barely 1%, and they carry a high cost. So the side effects of DPP-4 inhibitors or gliptins is GI side effects, upper respiratory tract infections, some joint pains in some patients. They have been associated rarely with acute pancreatitis. We need to reduce the dose if you have a chronic kidney disease, except linagliptin. Vildagliptin is available in Europe and some other countries, not in the US, and it has been rarely associated with liver dysfunction. So the guidelines recommend to do liver enzymes before starting vildagliptin, and then to monitor them every 3 months in the first year, and then after that periodically. And it should be stopped if the ALT is more than 3 times upper limit of normal. Let's talk about the GLP-1 receptor agonist. So they are generally effective, A1C lowering up to 1.5%. They are associated with a great advantage, weight loss, rarely to cause hypoglycemia. Liraglutide has been shown to decrease cardiovascular events and mortality in patients who are mainly with cardiovascular disease or who are at risk. Dulaglutide and semaglutide has been shown to decrease cardiovascular events in patients also who have cardiovascular disease or at risk for it. So one of the points with GLP-1 receptor agonist is that they are available as subcutaneous injection, and that may make patient acceptance a little bit of a problem. So we have exenatide, liraglutide, dulaglutide, and semaglutide. And we have actually the first oral form of GLP-1 receptor agonist, an oral form, semaglutide, which is approved. They may be associated with GI side effects, nausea, vomiting, and diarrhea. There's a question of an association with acute pancreatitis. It shouldn't be used for patients who have a history of medullary thyroid cancer, which is a very rare form of cancer, and they are one of the highest costs of diabetes medications. So let's talk about the SGL2 inhibitor. This group decreases a glucose reabsorption at the kidney so that you would lose glucose in the urine. And the agents available so far are canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. They are modest effect, again, A1C lowering around 0.6, 0.8%. They also have been associated with weight loss, some mild decrease in blood pressure, and they rarely cause hypoglycemia. Empagliflozin has been shown to decrease cardiovascular mortality in patients with cardiovascular disease, while canagliflozin has been shown to decrease cardiovascular events in patients who are with or at risk of cardiovascular disease. So the side effects, as you can imagine, because of glucose in the urine, you can have urinary tract infection, genital infections, dehydration, hypotension, and mild increase in LDL cholesterol. They are of high cost. They have been rarely associated with diabetic ketoacidosis, and canagliflozin has a warning of a side effect of increased risk of bone fractures. Thiazolidinediones, they improve insulin sensitivity, and the agent available mostly now is pioglitazone. It can be given at any time of the day, and the advantages is generally effective but variable. So the A1C lowering can be anywhere between 0.5 to 1.5%. It has been rarely associated with hypoglycemia, and it has a low cost. Disadvantages are weight gain, lower lymphedema, and increased risk of heart failure, especially in patients who are at risk, bone fracture, especially in postmenopausal women, and rarely a urinary bladder cancer, and it has a black box warning both from the FDA and European Medicine Agency. Insulin, basal insulin with metformin actually has been studied, and it's effective. The cost depends on which kind of insulin do you use. And of course, as you know, insulin is associated with hypoglycemia and weight gain. The main issue here, or two issues I see, is the need for education and training and patient acceptance. So a lot of time, if patients know that there are other options other than insulin, most of the patients will choose, and also physicians will choose other medication, especially oral medications after metformin. So this is the algorithm that we use that's based mainly on the American Diabetes Association guidelines. At the time of diagnosis, you start lifestyle changes and metformin. And then if the patient has atherosclerotic cardiovascular disease or heart failure or chronic kidney disease, the ADA suggests that irrespective of the A1C level or target, that if you have cardiovascular disease, you would start either an SGL2 inhibitor or a GLP-1 receptor agonist. The evidence more towards empagliflozin or canagliflozin, and for GLP-1 maybe mostly liraglutide. If you have heart failure, then SGLT2 inhibitor are preferred. In case of CKD, then again SGLT2 inhibitor are preferred. After 3 months, if the patient doesn't have cardiovascular disease, heart failure or CKD, then you want to add the next step drug if the A1C is not target, usually after 3 months. And here you look at several factors. If cost is a concern, then the choice is between sulfonylurea or a TZD. If weight is a concern, so you want to choose an agent that has a favorable effect on weight, either a GLP-1 receptor agonist or SGLT2 inhibitor. If hypoglycemia is a concern, so you want to use an agent with a low risk of hypoglycemia, and the options are DPP-4 inhibitor, SGLT2 inhibitor, GLP-1 receptor agonist, or a TZD. And then again, after 3 months, you look at your A1C, and if it's still not at target, then you add a third agent, and here it's going to be, in case of a cardiovascular disease, you would add the other agent, either a GLP-1 receptor agonist or SGLT2 inhibitor. For CKD, there's some evidence for liraglutide that it may have benefit, so it can be added after a GL2. For the cost, you can add a TZD or sulfonylurea. For the weight, you have the option of SGL2 or GLP-1 receptor agonist. And in case of the hypoglycemia concern, you can choose from one of those 4 agents. Of course, it's important to mention that a DPP-4 inhibitor and GLP-1 receptor agonist should not be combined because they work on the same system. So if the patient is controlled on 3 agents, I think that insulin should be considered. So let's summarize. So lifestyle changes and metformin should be given at the time of diagnosis. The choice after metformin depends again on several factors, especially comorbid conditions, the effect on weight, the cost, and the risk of hypoglycemia, also the patient preference. So you need to look at all of those factors to decide. You need to consider insulin if the patient is uncontrolled on 3 agents. I thank you for your attention. For more information and educational materials on diabetes, you can visit my website www.mohseneledrisi.com.